All right, everybody. Welcome back to the Gyno Gurus Podcast. It's been a few weeks since we filmed. I'm sure you all missed us very much. So a lot has happened in the women's health world this past week. So as Dr. Mandel was saying earlier,
PCOS apparently has been eliminated.
It is no longer a thing. But don't worry, it's just been renamed to PMOS, which stands for Polyendocrine Metabolic Ovarian Syndrome. So the thing is with the PMOS, the thing that's really changed is the name. How it's diagnosed has not been changed. So I was kind of reading a little bit about, what the process was to get the name changed. And basically what, the people were saying is that since a lot of women who have PCOS don't have cysts on their ovaries, which is true, that the title of the diagnosis was a little bit misleading and somehow led to people being like misdiagnosed or not diagnosed, leading to delayed treatment. And that's what caused the name to be changed. But I'll let Dr. Mandel speak to this in a minute. But I think from my perspective, I like the name change, obviously, because I think that it speaks to the metabolic depth of the syndrome itself, instead of just kind of focusing on PMOS as just a reproductive issue. This is a whole body metabolic endocrine syndrome. So I like that. But again, it's still diagnosed the exact same way. The criteria has not been changed. So yeah, what are your thoughts, Dr. Mandel, on the change?
Actually, as you were talking, I was thinking back to when I was in medical school, and they used to call it Stein-Leventhal syndrome.
Really?
Yeah. So,
wait a minute, because I thought that the name of PCOS had been around for like 90-something years, no? You haven't been around that long, Dr. Mandel.
No, there's overlap. And they used to call it Stein-Leventhal syndrome, and that has disappeared. So maybe, but PCOS was back there also, but a lot of clinicians would call it Stein-Leventhal syndrome, but it was basically the same. It was the same thing exactly as what it is now. So just watching another name change.
Yeah.
So, yeah.
Which you would have been around because the Rotterdam criteria didn't become a thing until 1993, I believe it was.
So I was definitely there when.
So prior to 1993, what was, like, I'm just curious, like, what were things back?
I have to remember the criteria for Stein-Leventhal, but it was PCOS, whatever criteria exactly we were using then. But I remember that they would do ovarian wedge resections. Mm-hmm. And what that is like a polycystic enlarged ovary. They would do biopsies on these ovaries to diagnose it. And then they found that by eliminating some ovarian tissue, it helped correct some of the underlying issues, and the patients would, some of them would start to ovulate again. And then a treatment that was kind of popular in I'll say maybe the 80s and early 90s was laparoscopically doing what was called ovarian drilling, where you'd go in laparoscopically and you would literally drill holes in the ovary, which was basically getting rid of some of those, cystic areas. And that would correct the some of the underlying misphysiology or whatever, dysfunction.
Which I will say, not we, but like specifically like the NAPRO technology, restorative reproductive space, like ovarian wedge resections are very much still a thing, alive and well. I know several surgeons who still do that. I believe actually the surgeon who did my endometriosis surgery a few weeks ago actually does ovarian wedge resections as well. But we're going to get to the pathophysiology of all of this and like why that actually kind of makes sense, at least to me.
Yeah. Well, it makes sense, but I'll tell you, I have some concerns about ovarian wedge resection because you're removing ovarian tissue, and you're clearly going to be removing some potentially viable eggs down the line. And so to me, I have concerns about causing ovarian failure earlier than it needs to be. Now, I'm not saying necessarily premature, which would be under the age of 40, but still having your ovaries produce the hormones that you're supposed to be having is very important to long-term health. So now, having dysfunction in those ovaries and producing excess androgens and which promotes like abdominal obesity, dyslipidemia, that's also a health issue. But so to me, like, if you had somebody who you really couldn't treat in any other way, that might be the place for it. But I find that's not very common at all, at least in my practice.
Yeah.
So.
So we're going to just kind of talk a little bit about just a little bit. This episode is really about the pathophysiology behind PMOS. And then we're going to kind of just tie that back to, obviously the name change, but then since there are changes taking place, it kind of leads to a question of, are there going to be changes to the diagnostic criteria of the new Polyendocrine Metabolic Ovarian Syndrome? So high level, the way that I see things with PCOS, so we kind of have this, technically it's called like the ovarian first, or like ovary first theory. Then you also have PCOS that's really driven by insulin resistance. And so what I think is interesting, which not a lot of people really talk about, is that PCOS actually really, for a lot of people, starts in utero. So we talk a lot about epigenetic factors, especially whenever these female babies are developing inside their mom's womb. So all that to say, when these female babies are exposed to things like elevated anti-Müllerian hormone, which is termed AMH, or elevated testosterone levels, it actually causes a underdevelopment of something called your kisspeptin neurons, which is basically a group of neurons that lives in your hypothalamus, and it's responsible for basically pulsing the release of something called gonadotropin releasing hormone, which is then responsible for releasing a hormone called luteinizing hormone, also called LH. So all that.
I just want to interject one thing. The hypothalamus is in the brain. So we're talking about in the brain.
Yeah, in the brain. Yes, I should have specified.
So
it's in the brain. So PCOS starts in the womb and in the brain. And so basically what can happen is when the baby is exposed to these hormones, you have an underdevelopment of these neurons in the brain. There's actually a study done. It was looking at like quite literally like the size of the area that was, compared to like females and males and men, the area of the kisspeptin neurons is a lot smaller. But then in women, it's a lot larger. But these women who actually have PCOS have a much smaller kisspeptin nergic system is what we call it. So basically, as that baby grows up and then starts puberty, what can happen is the underdevelopment of those neurons can cause hyperactivation, or basically hypersecretion of the luteinizing hormone. And if you remember from our last video, we're going to call it LH from now on. So luteinizing hormone means LH, or LH means luteinizing hormone. Basically, whenever you have these very, very high levels, which is what's happening in these girls who have PCOS, you're just pulsing out LH. It's acting on the theca cells in your ovary, which we've talked about before, and you're producing higher levels of testosterone and androgens than someone who has normal LH pulse secretions. So, and then furthermore, after you have the increased levels of testosterone, over long periods of time, those high levels of testosterone are going to cause you to develop something that we call visceral fat, just because obviously men have higher levels of testosterone, and where do men gain their weight? In their abdomen. And so you're kind of following that same pathophysiology. And then whenever you have more levels of, visceral fat, more abdominal fat, you're more likely to have insulin resistance. And then the effects of PCOS are amplified. So that's kind of one pathway of the development of PCOS. Sometimes we talk about like insulin resistance and PCOS, and it's like, well, what comes first, like the chicken or the egg? And, there definitely are types of PCOS that are metabolically driven by insulin resistance. But I do think that the ovarian or ovary first theory, I think, is honestly underappreciated in my opinion.
I think that's a very good point. When something called a syndrome, usually it means there's more than one cause.
One cause. We all end up at the same area, but it's like there's a lot of different ways to get there.
Exactly right.
Yeah.
So, but understanding the the underlying causes allows us to address it better. And so, for example, if a woman's going to get pregnant and have a baby, addressing that will hopefully break that, generational perpetuation of the syndrome. And like we were talking even before the podcast, like certain ethnic groups are more prone to insulin resistance than others. So it may not be the same in every population. And one other thing so we call it when somebody has like the in utero effects, like you were referring to, we call that epigenetic factors. In other words, you can have something in your genes, but it's influenced by the environment. So the environment influences how those genes will manifest the phenotype.
Mm-hmm. Yeah. And I think that phenotype is important whenever talking about PCO, just because, like you said, it's like syndrome entails a lot of things, and it's almost kind of like inflammation, which we've had that conversation. Yes. It's like a lot of different things will get you to the same outcome. But at the same time, it's like, I found like the more that I learned about like the different types of PCOS, and like, like lean type, reproductive type versus metabolic type, it's like you really do treat those things differently. Like obviously someone who has an elevated FSH or LH-FSH ratio, which we'll talk about in a second, I would treat them differently than someone who has a normal LH-FSH ratio and high insulin levels. And, eventually as time goes on, it's like those high LH levels will get you to the same place of having insulin resistance if it's not caught and treated appropriately. But, at baseline, it's like fundamentally they're both different. They're different pathways to get to the same place. But that kind of also goes into basically talking about markers of PCOS that aren't really actually diagnostic criteria. And like I said, I'm interested as time goes on, since we're kind of seeing some movement and shifting of, or changing names of things, is like, are there going to be changes in, the diagnostic criteria? Because kind of like Dr. Mandel and I were talking about before we started filming, a lot of people are really excited about this change, and they should be, because like I said, it definitely brings more attention to the metabolic depth and aspect of PCOS. But I think kind of what I'm not as impressed with is the fact that the criteria hasn't changed. So it's like the name has changed, but we're really doing everything the same. And so, they were kind of arguing, well, this could like lead to more diagnosis. I'm like, I think unless you actually expand and change the criteria, I don't think that there's going to be much difference.
I agree with you. I think it's important for clinicians and patients to be aware of the different aspects, because as a patient, you have to advocate for yourself. Not every clinician really keeps up as much as they can. And in all fairness, there's a lot of stuff that goes on in medicine. So keeping up with everything is a challenge for any clinician. We keep up with this, of course, because we're in the space of women's health. Mm-hmm. But like a family physician, or a pediatrician, they have the opportunity to diagnose a lot of patients, but maybe they don't. And it might be just because they're so overwhelmed with so many other things. So being your own advocate is really important.
Mm-hmm. Yeah. And just to kind of go back, like some of the markers that I may be thinking about that I think should be included potentially in diagnostic criteria, elevated LH levels. We call it an LH-FSH ratio. So FSH is follicle stimulating hormone. That's also a gonadotropin that also acts on your ovaries. But if you have a ratio, I believe it's what's the ratio again? It's 3 to...
So an LH to FSH ratio of 3 to 1 or greater.
Higher,
some people have used 2.5.
Yeah.
But I think if you hit 3 to 1, then you're likely have. And that really is in somebody who's anovulatory.
Mm-hmm.
So if, in other words, you're not getting regular periods. If you're getting regular periods, then...
and you also have to make sure you're testing it at the right point in your cycle as well, like cycle day 3. LH, FSH is what I personally do. So it's like if you have an elevated level on that day of your cycle, I would say that's pretty accurate. But yeah, so the 3-to-1 or I've even seen, I think some people say 2-to-1 or higher, but whatever, 3-to-1 we'll say for today. Elevated AMH levels, which is the anti-Müllerian hormone that we were talking about. And can you just like briefly kind of overview tell us like what causes those levels of AMH to be higher? Because I feel like that can be confusing for some people.
So it's related to the number of follicles. So it sort of reflects the polycystic, when I say polycystic nature, what I'm referring to is on ultrasound imaging, what you see is an enlarged ovary, and really only you need one ovary technically with ultrasound to meet this standard, but you have an enlarged ovary that has multiple small cysts. Those cysts are really like eggs that are potentially could progress to be to release release an egg. So they're where the eggs kind of live and are stored, but they just stay in suspended animation, if you would, in the ovary. And so you see a lot of these little follicles, and they're all like hormonally dysfunctional. Mm-hmm. And so if you actually go into that follicle, you'll see like elevated androgen levels, elevated inflammatory cytokines like insulin, like growth factor 1 and 6. You'll see TNF alpha. These are all just terms which are so into the weeds. You don't have to worry about them, but they're inflammatory markers, and they prevent that follicle from developing. So reducing the inflammation is going to one of the ways to help correct the problem. But you have when you're diagnosing it, you're going to see all these little polycystic.
Which in the blood test, like the more follicles, the higher the AMH.
And so the AMH, which is where we started from when I ran off on this tangent, reflects the number of those eggs.
Yeah. Yeah.
And that's on the flip side when you see somebody who has, when their ovarian reserve, like somebody's getting older and you're worried, can they get pregnant again? Their ovarian reserve is getting lower. They have fewer of those, and your AMH level is going to be low. Mm-hmm. So it's sort of the yin and the yang there.
Yeah. So those are the two so far. So we talked about LH, FSH ratio, AMH. Another marker that I think would be wise to be considered would probably be fasting insulin levels. And then, of course, agree. Keeping the androgens, the polycystic ovarian morphology, irregular periods, all of that stuff. But again, I think, like I said, I think that's kind of my main, not my main issue, because I don't.
I'm going to throw one other thing in here. A lot of, especially for young people, when a young person has like elevated high cholesterol, particularly high triglycerides, I don't know whether it should truly be in the diagnostic criteria because there are other causes for those things, but it should be a big red flag for like a pediatrician or a primary care physician to start looking at that. Because that is really, to me, very important, knowing the cause of it so you can address it, because cardiovascular disease starts when you're young. Mm-hmm. It develops slowly over time because we all have reserve. But if you don't want to have heart disease or cardiovascular disease, which can lead to stroke too, when you're, say, not really that old, but older, the time to really prevent it is at the beginning.
100%. 100%.
Yeah, and autopsy studies in like children who die in car accidents, they'll see fatty streaks in blood vessels, which are the beginning of plaque.
That's scary.
So it is important to be aware of these things, and like, and especially as a patient, if you're a mom and you have a daughter who has an abnormal lipid panel, maybe a pediatrician did that. That's one of the things that should really be looked at because there's a whole connection there.
Definitely.
Yeah.
Yeah. So all that to say, I think, the culture of change is good. I'm hoping that it just doesn't stop there, because I think that will serve women better in the long run than just changing the name of the, syndrome. So all that to say, I think that's really all we had for today, unless you have anything else to add. I think that was a good discussion though. And I'm excited to see kind of where things go in the future. Cause like I said, I feel like the stage is kind of set. And so now it's kind of like, well, what are we going to do about it? Like, are we actually going to continue to, push and make, cause I mean, if we're really trying to not underdiagnose and delay treatment, I think it would be, worth expanding the criteria, and that will 100% lead to less delayed diagnosis and delayed treatment. So that's kind of my 2 cents on it. But yeah, do you have anything else to add before we close?
I'm totally with you, but I'm glad to see we've PMS is no longer.
PCOS is no longer.
I'm sorry, it's PCOS.
PMOS is in, PCOS is out.
I'm
adjusting.
mixing up my
You've been around for a while, so it's okay. It's going to take some adjustment,
Yeah,
I think.
so it took a while for Stein Leventhal to go away.
I know. Well, yeah, you've lived through it all, which is very cool. So anyways, but thank you guys for watching. If you have any thoughts or comments about this, please leave it down below. Thank you.